Now the next session will be live transmission from Germany. I have the pleasure to invite Professor Ahmed Nassar, Hussam Andil, Khalid Ennadi, Mohammed Osman, Mohammed Saad.
Eine Folge wird ja sein, wir haben ja besprochen,
Proctor
Teambegrüßung, Patientenvorstellung.
So, do you hear us?
Okay, I'm hearing funky noises, but no human voice.
Okay, we are hearing you very well.
I hear you very well.
Okay, and we also, yeah. Welcome to our conference.
Can you hear us?
Yes, yes. It's a great pleasure to have you from UKSH. It's a
Perfect.
So you can go on. We are.
Okay.
I see that you have started your transesophageal echo.
The pleasure is with us. Exactly, and we've punctured the groin. This is where we are now. But let me quickly introduce my team then, okay?
Okay, let's go. Go on.
We're also very pleased to be with you in Cairo. Great honor for us to send a live case. My name is Felix Kreidel. I'm the head of the structural heart team. I'm going on, okay? On the interventional side is my colleague Tim. The echo star is Raphael doing the echoes today. He's going to present you the LAA morphology. And then we have from our nursing staff, Marina and Anya. And Chris Dunbar is with Abbott supporting us by the company. And next step would be the presentation of our case. Next slide, please. This is actually our team, and this is how we look like without the masks. Maybe you're interested. Mohammed Saad, you know probably also well. He's going to be with you, and Dirk Frank, the guy in the bottom row, is our boss. He's not with us today. Next slide. This is our patient, a 78-year female patient with permanent atrial fibrillation. Was diagnosed in 2011 and never been really feasible for rhythm control. And over the last month, she's presented recurrently with lower GI bleeds under anticoagulation with apixaban, and also despite off-label reduction, she kept on bleeding. Chatsvask, as you see, is 4, has bled score is 3, ERA score is 1. Next slide, please. This is her past medical history. It's positive for dilative cardiomyopathy with a mildly reduced ejection fraction. She's under CCM and doing quite well in New York Heart Functional Class 2. She has chronic kidney disease, and her most relevant risk factors, cardiovascular, are arterial hypertension and the BMI of 44. Next slide. This is her medication, classical heart failure medication, and her recent lab results are an elevated BNP. Hemoglobin is still okay, and she has a reduced kidney function with a GFR of 38 milliliters. Next slide. So what did we consider for her to be meaningful? We felt like that she's not a good candidate for continuing the anticoagulation, and we obviously want to avoid further bleeding. So we opted for an LAA occlusion, and since she has that reduced kidney function, we're actually going to present you a case of LAA occlusion without the use of contrast, and this is why we've opted for transfemoral echo-based only LAA occlusion with the Abbott Amplatzer system. And now I'm going to throw the ball to Raphael, and he's quickly going to guide you through the morphology of the LAA of our patient. Raphael.
So perfect, but can you please zoom in for the echo? So it's okay.
Yeah, we can do that. Koza, your job, please. Very important. Yeah, that's just to wait for the company is actually maneuvering the camera. Are you happy?
Yes. It's better now, yes.
Very important information. You need to see what we're doing. Yeah. Okay.
So So now it's okay. We are seeing. We are have the view for the transesophageal echo. So you can go on. Okay.
You're good.
So can you please?
Okay. Max view, Raphael. I think worthwhile. Max view, machen wir Max view then.
So
I think this is beautiful images, Raphael. Go on.
So okay, we are seeing your beautiful images, but can you please explain what you are what we are seeing right now?
Yeah, Raphael, go on. That's the lateral commissure of the mitral valve, and Raphael, show them the aortic valve. So this is a view, actually, we're sitting on the medial, aortic valve is at 3 o'clock. We're actually sitting, no, down, 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 down. This is aortic valve. There you see the aortic valve going open, and we're basically sitting on the medial aspect of the mitral valve, and we're looking up to the left atrial appendage, which is in the very center. And above that, you see the upper left pulmonary vein, and that prominent stretch is the so-called ridge in between. And below at 6 o'clock is the mitral valve. Maybe, Raphael, you go back two loops and show the basic measurements before you go to multiplanar reconstruction. So this is how we start. We take the primary imaging plane to 40 degrees. Raphael, and what did you measure here? So we're using biplane imaging from two different primary planes. 90. So we do that at 45 and at 90 degrees. Raphael, what did you measure here? So keep in mind it's something in between 90 and 20. And now what we really appreciate and love to do is we're taking the 3D volume and then doing multiplanar reconstruction. And we really believe in 3D imaging of the, yeah.
So please,
okay, go ahead.
So please, can you just start from how to we can recognize the neck and the ostium, so we can how you have the measurement to select your device, and please tell me why do you have selected the AMOLED device for this patient?
Exactly. We stay, Raphael, what you can do now in a second is just to do a live MPR. I think that's very, very didactic. And you can see here, it's a pretty narrow LAA, and this was the main argue for us to use a amulet, a lobe disc device. So we didn't want, or we felt there was not a lot of depth. So this is 3D, and we save a volume. Kann jemand zu Raphael gehen und einmal die Sonde festhalten, bitte? And Raphael is now going to do the multiplanar reconstruction. So whatever ecosystem you use, be it Philips or GE or Siemens, they all have this option to multiplanar reconstruct the 3D volume. And we're using that frame in which the LAA is biggest. So in a patient with AFib, the point in time of the heart cycle doesn't matter that much. But if you have a patient with sinus rhythm, then of course it does matter. And you nicely see in the upper left image, you see the circ, orthogonally cut the circ. And now, Raphael, where do you put your primary measurement? And just, I want to point your attention to. But that's really if I may interrupt for a second, Raphael, I think really the beauty is that you have the landmark of the circ in the left upper plane, and if you then choose your landing zone, you mark it by putting the blue line exactly on that landing zone, and as the blue line moves in parallel in the two upper boxes, you then can easily decide where to measure your landing zone in the left, in the right upper box.
So,
and for those of you who like 3D imaging, in the left lower, of course, you have the orthogonal cutting plane of the landing zone. And if you look at the left lower panel, you can see that it's a pretty round landing zone. And Raphael could, by moving red or, yeah.
So please, just for the audience here,
Go ahead, please.
Because we don't have a lot of experience. We don't have a lot of experience with left atrial appendage closure, so not everyone here is.
Are you convinced, or do you want to know something else?
Yeah, we just want to know where is the neck, where is the ostium, and how do you measure it, and how you have all your measures to get your perfect sizing for the device. So I see that you have the left circumflex on the left side of the appendage, and you just go up and down. Just need to have 1 centimeter or 10 to 12 millimeters just below, yeah?
Okay, so the ostium. Yeah, exactly. So, yeah, the honest answer is there's no super definite position. What you always have, so this is another argument why multiplanar is so beautiful, because you always see where you are in another cutting plane. And Raphael, go up to the ostium in the left upper with the blue line. So if you measure the ostium, this is actually the ostium. If you now turn the blue line and go to the top of the ridge, this where the blue line is now, that's the ostium. And you can tell in the left upper box that you're pretty far away in the left atrium already, as it's not a flat plane, the ostium. The ostium is funnel-shaped, and medial-laterally it is further into the left atrium. Medial-lateral, you see circ versus lateral on the opposing side. And if you look at the upper right box, you have inferior and superior. So you want to find a landing zone that's at the neck in both planes, and that is typically 2, 3, 4, 5, up to 10 millimeters below, distal from the circ. So if Raphael is pulling down the blue line now, you see that only now you have a nice landing zone in the right upper box. So the ostium is really very proximal, and the landing zone is further distal in the LAA. And typically it's roughly 5 millimeters distal from the circ.
Okay, perfect.
So, and if we measure now 22 as a max diameter, and we are opting for a device with a certain amount of compression, obviously these nitinol devices need some compression to actually anchor and not luxate into the... So, and what we want is 10 to 20% of oversizing to have a decent amount of compression. And we have 22 by 21 millimeters, and this is why we opted for a 25 millimeter amulet device. And to give you another very honest answer, this most probably would also work well with the Boston device, but in this lab we're very familiar with Abbott, and as said, if you look at the right upper box, superiorly on the right, it's pretty deep, the LAA, but on the opposing, the inferior part, it's pretty shallow. Okay, go exactly here. So inferior, it's pretty shallow. Anterior, it's more deep. So, and if you take a disc lobe device, then you just stay away, and you can be pretty calm regarding the depth. This was actually our strongest argument to use amulet.
Okay, and now have you started
So
your
I
septal
think
picture?
looking at the time, we would decide now to do a transeptal. If you're happy with our evaluation, and actually we've prepped already a 25 millimeter amulet device. Exactly. So I had a preface sheath in the left, no, in the cava superior. My radiation is AP. Did we move down actually? It could be, no? So actually I'm moving. No, give me the wire again. Like while we were preparing the case, the sheath actually fell down into the LA and into the RA. So what we're doing now is we go all the way up in the cava superior again. Okay, here we are. I show you in a second. Can you see the fluoroscopy well?
So we are just watching the transesophageal echo. Can you just zoom
Kyle,
out?
can you see the fluoroscopy?
No.
Are you happy?
Can you please zoom out from the echo?
Okay, so I pull down.
We don't see the fluoroscopy. Can you please just zoom out from the...
Okay, yeah, that's relevant.
Okay.
Exactly. Type.
Okay, it's okay.
Exactly. Yeah. We have a technician in the back. Koza, would you be so kind and zoom out? Raphael, zeig mal kurze Achse bitte.
So you can zoom out so we can see both the transesophageal echo and the fluoroscopy together. So. Yes, it's perfect, you know.
Könnt ihr vielleicht den Monitor einen Ticken so drehen, dass die Kamera noch besser draufschauen kann? Raphael, ich sehe dich, ich sehe mich nicht. So obviously this is a little more immer die kurze Achse, Raphael, das sieht, glaube ich, perfect, very good. Okay, so obviously transeptal puncture is super relevant. And because the trajectory into the LAA needs to be good. Raphael, zeig mal kurze Achse bitte. Monoplan, kurze Achse. And the rule of thumb is you want to be centrally in the fossa and inferior. And you probably also see by fluoroscopy that we're entangling with that CMM system. You see that? I'm pulling down one of the ventricular leads. I'm trying to let go one. This is better now. So I counterclocked my needle, let go, and it didn't work too well actually. So what is relevant now for the echo? I want to see the so-called tent. I want to see my needle interacting with the septum.
So.
And I'm not so happy as Raphael is not showing it to me very well.
So you need to be inferior.
Going back.
You need to be inferior and posterior, yes?
Kriegst du irgendwie einen Tent eingefangen? Nicht so richtig, ne? And posterior, exactly. Okay, now we have a tent. Raphael, zeig dir mal kurze Achse bitte. Ich glaube, du musst die Sonne ein bisschen rausziehen. So, we look at the short axis with the aortic valve. What you definitely want to prevent is to be too anterior. So, if there was a PFO, for instance, don't take the PFO, because as the LAA is typically anterior in the left atrium, you want to enter the left atrium posteriorly on the opposite side. That's the rule of thumb. If you enter anteriorly, then you're very oblique in your trajectory. So you want to be posterior, and posterior means in the short axis to be further towards the posterior wall. But apparently this is so. We've passed the septum and kind of accidentally just by adding push. And Raphael is now giving you a 3D volume of the left atrium. We do that to control the trajectory. This obviously doesn't work in. Ich glaube, du musst eine andere. Mach mal 3D Zoom. Such dir mal eine andere Position, bitte. Raphael, du bist zu weit draußen. Übersättigung ist 100%, alles gut. So patient is coughing. Nee, jetzt bitte nicht absaugen. Jetzt bitte nicht. Ich brauche jetzt erst, Raphael, wir sind mit der Nadel drin. Okay, dann müsst ihr jetzt doch also der Zeitpunkt könnte nicht absurder sein. So we're struggling with the patient for a second. Okay, so you know what I'm going to do? I'm just going to secure my needle. I'm just going to go left with my sheath. Am I left, Raphael? Mir einmal zeigen, bitte. Ja, okay. So, as you can tell, we've moved to the left atrium, and it was just kind of Murphy's Law. It's just when we needed the calm 1 minute to exactly show you that 3D volume, the patient started coughing. But we're fine now with the help of the big team. So this is our transeptal sheath in the left atrium, and Raphael can probably give you now the 3D volume we were talking about. And you can already by this very beautiful cutting plane, you can get an impression that we're really on the opposing side of the LAA. And 3D can illustrate that very nicely.
So you are penetrating the septum, yes?
Gib mir nochmal einen
And
Bauch.
just you are in the direction for left atrial appendage.
Here. So that's beautiful. So you see, that's a pretty straight shot. So at 6 o'clock, there's the right atrium. You have our sheath going from the right to the left. Yeah, so exactly. You get the story. So and imagine if you're too anterior now, then your trajectory is oblique and you will have difficulties implanting your device.
So just for explanation for the audience,
So
for the
now comes our stiff wire. We have a patient leg that's moving the. Okay, what's the question?
no, it was just for the previous image that for explanation for the audience that the cheese is passing through
I'm not
the
hearing you
left atrial
anymore.
appendage.
Unglaublich, dieses Patientenbein hier. Vorsicht, Tim. Hol das mal raus. Ja. You want to see it again, the 3D volume?
Yes, we just need explanation for this. That the cheese
Raphael is
that
probably being so kind and generate it again. Here you go. Max view, Raphael. Perfect. So we hope you can see this nicely. Yeah.
Yes, now at 6 o'clock it's the right
Okay.
atrium. Yes?
So at the can you kipp mal ein bisschen nach unten das 3D-Volumen noch? So at 6 o'clock at the lower part of the image, that's the right atrium, and Raphael's white arrows just at the sheath. So exactly, and the sheath is passing from the right atrium to the left atrium. And Raphael, show the left atrial appendage.
So it's at
It's
12
over there.
o'clock. Yes.
And at 9 o'clock, you see the medial commissure of the mitral valve. Raphael, show the mitral valve. That's the mitral valve. Vielleicht kannst du mit dem Trackball das ein bisschen runterholen. Du musst den Pfeil wegmachen. Ja. So actually, I was wrong in one aspect. This is not the sheet. Oh, das ist nicht live, Raphael, oder? Is it live? No. Okay, are you all happy? It's actually, you can see the tricuspid valve down here at 6 o'clock. You can see the mitral valve. You can beautifully see the interatrial septum and the transeptal sheath that's passing from right to left. So if you, Raphael, mach mal live. Super. So now we have our stiff wire. It's an Amplatz extra stiff that is in the left upper pulmonary vein. You see that?
Yes.
You see the LAA and you see the ridge, which is the thing in between, and then you see our echo bright wire. So that's the big strong rail we're using for our sheath, for the LAA sheath to go in. Raphael, zeig mal septum bitte.
So you just support your system by this stiff
So
wire in the
now
pulmonary
we're there by
pulmonary-
fluoroscopy. We've lost the wire position. Are we still in the left upper pulmonary vein, or did we fall into? Yeah, we're still good. Okay, so the sheath is exactly. That's so through the transeptal sheath. I put that extra stiff wire all the way up into the pulmonary vein. I take out the transeptal sheath, and now I have the dedicated Amplatzer double S curve, and I put all the way up here. Raphael can probably show you a nice 3D on how this, on how this sheath is now positioned in the left atrium. Actually, we're very deep in the left upper pulmonary vein. I just pull back a little. Machen wir mal das hier. Mach doch noch einmal schönes 3D. Das habe ich mir schon genommen. So, now we have the big sheath. That's pretty much the same image we had before. You see the left atrial appendage, you see the mitral valve, and the thing I'm moving now, this is fluoroscopy and echo, that's the tip of our dedicated sheath. And I'm pushing myself a little further forward towards the left atrial appendage.
So for this
what is
patient,
the next thing we do? Maybe one information regarding safety. Now with the big sheath, you definitely want to make sure that you have unrestricted. Yeah.
So in this patient, you will not use a pigtail for injection because of kidney injury in this patient. So you will just depend on the echo for positioning of the device.
Exactly. So this can only work if you have a very dedicated and safe echo protocol. So, also in the interest of time, I'm going to connect.
Can we see the loading of the device
I'm going to
on your
connect the
hands?
device.
We just need the camera to.
Super important is now that you make sure that there's back bleed. But as we have a heart failure patient, Jim, give me a chair. No, the loading, it was done already. It's preloaded, so we can't show you the loading. It comes preloaded out of the box. So it's nothing to show. It comes inside the transducer, you flush it, you connect to the sheath, and then you push forward. You just need to make sure that you have back bleed. Very important. But in a patient with chronic heart failure, obviously LA pressure is high, so we're safe. But if you do this in a very healthy person, then sometimes LA pressure is low, and then you need to be very careful. So I'm slowly pushing the device forward.
Okay, so we need to see the fluoro and the echo, please.
Sure that I give time to back bleed. Okay. Okay, so now if you see the fluoro, you see that the device is about to come out. I pull back the device a little bit to control that it's really nicely mounted onto the catheter. I save this. The next step is now to develop the device a little bit until it forms to such a atraumatic, let's call it olive or ball. And now I'm going to ask Raphael to give us a biplane view in order to find the entrance to the LAA.
And so the device is going outside.
You see that I'm too inferior, right? In the right image, we want to go further to the right, and that is a counterclock turn. Can you see? We can give you a better contrasted fluoro. We're not going to save radiation for you. Now you see it better, right?
Yes, yes. So you get the device out in 2 steps. The first part is the olive and then the disc.
Okay, now I work myself into the LAA. You see that?
Yes, on the right side, yes. On the left side.
Yeah, no, but it still is only olive. So
Yes.
I use the olive to engage in the LAA. On the left also. It's really now all in Raphael's hands to give us great images. And the fluoro, the C-arm, I put in an areocaudal projection. That's relevant to understand. That's the same imaging plane like the right echo image, only that it's counterclocked by 90 degrees. So if you focus on the right echo box, what is right there is up in the fluoro. But other than that, it's the same imaging plane. So now I think we're actually very nicely seated at the landing zone. Zeig uns mal das rechte Bild ein bisschen besser, Raphael. So I'm developing the device. Bisschen tiefer, oder? So we think we're not deep enough. Actually, I'm not, yeah. So at the inferior aspect, I would like to be a little deeper. So I can easily recapture.
Mm-hmm. And how do you select the loop?
And go a little deeper. We like this better. Oder soll ich noch ein bisschen kleiner machen und weiter reingehen?
So how do you select the loops that you go inside for the best deployment of the device?
What do you mean by loop?
The loop of the appendage. So when you have multi loops of the appendage, which one do you choose for the best deployment?
It's always exactly. I don't like that too much. Let's. You mean the echo loops, or? So we're not absolutely happy with the device position. You see that?
Yes, I think
on the left side, the disc is not really nicely sitting in front of the ridge. Mm-hmm. So I think we need to recapture once more.
And you'll go deeper?
Einverstanden, Chris? And I would suggest to actually be a little further proximal. No, instead, I would actually decide to go a little further out. Chris, einverstanden? So it was also very squashed. So I like this position better. Well, lange Achse, not good, right? Yeah. So you see in the right image that we are actually inferiorly not nicely connected. So that's pretty much a challenge now, that we anchor inferiorly. So we can do this very slowly. Very slowly. Is it anchored? I think it's just anchored. I also like the fluoro. Right.
Looks better, yes?
So now let us pull. I think it does look better. I'm not so happy about the inferior aspect.
So let's get out.
But anyhow, we're gonna do a pull test, and it's out. So that's a positive pull test, guys. So I would suggest to try this one more time. That's a very didactic case for you guys. Mm-hmm.
So just for more explanations that
So we're in again.
after deployment of the device, you make like a tag test to try to pull it out, and it just got out with you, yes?
Wait a second, Osmatu. Give me 1 second. I'm very concentrated in the moment. Uh, 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 uh. Das hebelt den da raus, ne? Ja. Okay, so we're not happy about the depth. I recaptured for the 3rd time. So that's a challenge on the one hand. On the other hand, you can see how controlled we are doing this. So we're actually going a little bit further in as you suggested. And now I'm very slowly pushing forward the cable that's connected to the device. And you see in the right image exactly the inferior part of the LAA where we do want to anchor, and this is the part we've missed. So I'm now being very slowly pushing the device in. So it's leveraging us always in that position inferiorly, not and we're also high on the inferior aspect, right? You like it? Or let's do a pull test. Let's be systematic. So it's actually now anchoring, right? Yeah. Actually now we're happy.
Yes. It looks stable this time, yeah?
So I mean you see in the left image. Exactly. That's not live yet. That's our pull test. Krieg nochmal ein Bauchtuch bitte. Okay, so medially now we're actually looking at 4 different spots, right? We have the left image, we're close to the circ and the opposing wall, and on the right image. And this is where Raphael is going to measure compression now. And as said, okay. How much was it? Da, genau. Okay, that's 20, 22, 23-ish. That's pretty much what we expected. And on the other side, ja, sieht echt gut aus, ne? So it's 23. That's the 10% we were asking for. On my live. Also, we like the fluoroscopy. It has actually a very decent shape. On my explain. So we invest in another pull test. So is it going to fall in or tilt a little bit to the left side? Okay, so can we, so go back to biplane, please. So we're still not very happy about the inferior aspect. Shall we give it another try? Okay, let's give it another final try to. We're gonna try to be perfect for you.
So why don't you have a color to see if there is how much is the leak right now?
Because if you see a leak with your eyes without color, you pretty much know that there's color. So this is the last call. I'm going to be very slow now and trying to implant it in a very, very low position. That's better. I think this is what we all like to see. Now pretty much 50% of the device is inside on the inferior aspect. You see that?
Mm-hmm. Yes.
Compression is also a little bit more profound. Okay, live, please. Achtung, Marina. So let's try to bring the. So ideally, we would bring up the lobe in front of the ridge, but this ridge is pretty prominent. But now we need to find a good compromise, I think. This is the best position we've had so far. We have a beautiful implantation height in the left image, and on the right image, it's actually a little bit too proximal. But look at the cable, how it is connected to the device. In the right image, you see that it's running towards 2 o'clock, so there's still some pull to the superior aspect, as our transeptal puncture was actually a little bit higher than you would like to have it. So my bet is that if we unscrew now, that the device disc is also going to fall a little bit to the left side, and we have a better seal than we are having now. So we had a decent pull test. Rafael, number 2D, please. So a final pull test is good, so that I decide to unscrew. And you saw how the lobe fell better on the inferior side. And there's a tiny thrombus, I think, on. So this is not live.
Yes. No.
I give you a decent fluoroscopy. So can we have a little more heparin, please? If you look very closely, this is a typical live case finding. As you're investing more time than usually, there's a tiny little thing on the lobe, which should go away with another 5,000 units of heparin. So this is a real life, very decent implantation of a quite challenging anatomy, as it was very shallow inferiorly, but I'm personally very happy.
Yes, I think it's well seated, and and this is a nice view for the appendage with the closure device from the above. It's beautiful, yes.
Exactly. So you can see how nicely it actually fits in the morphology of the left atrium. And we are going to pull back now. Maybe, which is also interesting for you, is to see how we close the groin. I had a ProGlide put in front, and I don't know whether the camera is actually seeing this.
Yes, please. We just need to see your hands, okay?
Ja. Tim, du ziehst einfach mal raus. Ja. So we're pulling back the double S curve. And despite a lot of units of heparin, there's no bleeding. I push down the knot.
Oh, it's a venous, so it's okay.
Yeah, it's a venous proglide, of course. I mean, obviously, a suture of 8 also works, but we like to invest the extra euros to have this beautifully closed so that the patient is up and running 2 hours earlier than with a suture of Z.
That's perfect.
Okay? Any further questions?
So thank you very much for this illustrative case. I think it's not an easy case. It was beautiful with multiple challenges. So do you have anything to recommend in this anatomy in later cases for anatomies like this?
Yeah, very good question. I probably would have liked to have a lower transeptal, that it would have probably made the trajectory a little bit easier. And I think it's also for me, after hundreds of these procedures, it's not easy to predict how the device is going to interact with the ridge. So this is the combination of a shallow LAA and a very prominent ridge gives you a challenge. I mean, you see that in this nice view that the lobe is not at the very ridge, at the very edge of the ridge, but it's not far away. So the distance of the ridge to the lobe is maybe 7-8 millimeters. So I think that we're not going to be having problems over there. I mean, you always fear that if the lobe goes down towards the landing zone, it's not standing on the very ostium, that you create a region of low flow and then have thrombus formation on the device. But here I'm actually quite happy that despite the difficult anatomy, the lobe position is absolutely okay.
So
that is my final words, I guess.
So thank you very much, and hope we have you in the next time in person here in Egypt.
Of course, that would be great. Yeah, thank you very much for having us. It was a big pleasure to send live images from the Baltic Sea to the Mediterranean Sea in this very rainy February we have here.
Awesome. Thank you very much. Okay, that's all.
Okay, bye-bye. Take care. Have a great Congress.
Thank you.